Now, some people have said, well, there's European data that contradicts that. Not really. That, when our paper came out in the New England Journal, the ALMS-Maintenance Trial, Fred Houssiau wrote the editorial, and I think he's explained it in that editorial. He did a maintenance trial based on the Euro-Lupus data. It's not really different. What he did was he took Euro-Lupus patients, everybody gets the 500 milligram mini pulses of cyclophosphamide, 6 doses here every 2 weeks, and then he randomized them to either get oral azathioprine or oral mycophenolate maintenance for 4 years. So it looks like a great study design. Here are the results. If you look at the probability of renal flares, which was his endpoint, it was 25%. This is the probability of not having a renal flare. The MMF was better, but not significantly so. But 25% of the azathioprine group had a renal flare, only 19% of the mycophenolate. So why is this so? First of all, the endpoint is much softer. Because this is a European trial, these patients do well. We know they don't go into renal failure. You're going to get nobody in renal failure at the end of time because he's already shown that. They're all Caucasian. So you'd expect the curves to do very well. You have to use a softer endpoint, renal flares. Moreover, if you look at these numbers and you say, well, wait a minute, that's not statistically significant. It's not, because you're only starting with less than 100 patients. The ALMS trial had 227 patients. If you had another 150 patients in the study, it might have been statistically significant. In fact, it probably would have been. It's probably all a matter of numbers. So the punchline of this is lupus nephritis patients do well if they achieve an initial remission after modern induction therapy. Maintenance therapy with 2 grams of mycophenolate or 2 milligrams per kilogram of azathioprine is very well tolerated and leads to excellent results at 3 to 4 years. Longer maintenance therapy should be considered in all patients after induction now. I think we should at least consider it. You may say, I can't do it for the following reason, but you should be considering it. And mycophenolate may be more effective, especially in the U.S. and minorities, but it's not overwhelmingly so. I mean, this isn't one of those things that you're making a mistake if you use azathioprine. A lot of people say, oh, my patient, is interested in getting pregnant and I don't want to put them on mycophenolate. That's fine. Then put them on azathioprine. The data is actually very good for azathioprine, especially in Caucasians. But again, the data is a little bit better for mycophenolate. The big thing is using the full doses for 3 to 4 years here, not cutting way back until you get a little further out in time. Now, I don't think these 2 slides are in the syllabus because I added them on. These are recent data from the American College of Rheumatology. I just want to show you where the rheumatologists are now. For induction, mycophenolate and steroids, you can get pulsolumedrol, or you can get cyclophosphamide plus steroids, with pulsolumedrol is allowed here. You can either get it, this is sort of fading here, it's a Euro-Lupus regimen or NIH. They still list the NIH data. Again, most nephrologists would say if I'm going to use cyclophosphamide, I'm using it on the Euro-Lupus beta. Again, there's lots and lots of data accumulating on that. For maintenance therapy here, if you start with mycophenolate and you're improved, you go to mycophenolate or azathioprine. If you start with mycophenolate and you're not improved during induction, you get switched over to cyclophosphamide to try to induce a remission. If you start with cyclophosphamide and you're improved, you go to maintenance with mycophenolate or azathioprine. If you start with cyclophosphamide and you're not improved, you get switched over to MMF. So again, this is very rational therapy. It's based on large randomized trials. I don't disagree with anything except that I would lean away from that NIH older, more toxic regimen. Now, let's turn to one other drug, which has been a relatively big player in nephrology, Rituximab. So this is data from the French autoimmunity group. The French autoimmunity registry has 136 lupus patients in it here. I don't want, it's a rheumatology-based thing, and I don't want to go through any details here because they use scoring systems to show how much better you are. But essentially, 3/4 of the patients who got Rituximab did better. And they thought they did significantly better, and they said the drug is great for this, and this was just a few years ago. But if you look at the large control randomized trials in lupus or lupus nephritis, they have been negative. So let's look at the only large randomized blinded control trial of rituximab in lupus. This is the LUNAR trial here. Now, Brad Rovin, as you can see, we've got a nephrologist as our, even though it's an arthritis and rheumatism, a nephrologist is the first author here. So if you look at this trial here, we had 140-something patients in it. Everybody got the same dose of steroids. They all have, by the way, diffuse or bad focal proliferative disease. There's no membranous in this. These are all solid, bad proliferative. They're all in the U.S. So 140 patients, everybody gets Solumentrol here, pulse, steroids tapered down over a year. Everybody gets a full dose of MMF here, a full dose of MMF here. This group, this 72 patients, gets IV rituximab, 1,000 milligrams, 2 weeks later, 1,000 milligrams. 6 months after that, 1,000 milligrams, 2 weeks later, 1,000 milligrams. This group gets placebo, 2 weeks later placebo, 6 months later placebo, placebo. Double-blind randomized control trial. 1-to-1 randomization, 72 patients in an arm, 80-something, 90-something% of patients completed the study. This is very good in terms of analysis. You're going to get real results. If you look at the punchline of this study, at the end of 52 weeks, the no response rate, that is, the rituximab was no better. So the placebo group, 54% were considered non-responders. The rituximab, 43%. Now, it looks like the rituximab has less no responders, but it is not statistically significant. It is not. If you look in some groups, this is now response rate here. So if you look in some groups, yeah, in blacks, the rituximab looked significantly better than placebo. In Hispanics, it looked a little better. In Caucasians, it looked exactly the same. The trouble is, these are all small subgroups. There are not enough patients to analyze independently. Again, remember the ALMS trial had 370 patients. You could analyze all of this data independently. So if we look at the LUNAR rituximab trial, the conclusions are, it's the largest randomized placebo-controlled trial to evaluate rituximab in lupus nephritis. Although there were more responders with rituximab, 57% versus 46%, there was no statistically significant difference in this number or any clinically significant secondary endpoint. If you said proteinuria, if you said number with hematuria and proteinuria, no matter how you looked at it, you could not show a statistically significant difference. It did have a difference on anti-DNA and complement. The rituximab group lowered the anti-double-stranded DNA faster, and the complement came up more at 1 year. But of course, that does not translate into benefit for your patient if the proteinuria, hematuria, and the creatinines are the same. Adverse and serious adverse events were similar in frequency. There was no unexpected safety signal. I can say there was no progressive multifocal leukoencephalopathy in any patient in any of these studies, either with MMF or rituximab. That just was not an issue at all here. The drugs came out about the same. Now, how do we interpret this? You can interpret it a number of different ways. One thing you can say is that the problem with this study is they only had 140 patients. Now, I told them that in the design initially that we needed more patients. The company that did this, Genentech, said, no, our statisticians say that this is going to give us a significant difference. Well, they were wrong. It didn't. Or you could say they didn't follow them long enough. Maybe another year's worth of follow would have shown that all those serologic differences made a difference. They didn't want to do that. Or you can say rituximab doesn't work when added to a full dose of mycophenolate and steroids. It may be that it just doesn't add on enough at that group to show a difference unless you had 800 patients in a study. So again, it gets harder and harder to show a difference if you have a full dose of therapy in both arms. Now, some people criticized the designing committee and me in particular, because we had a full dose of mycophenolate in both arms. They said, why don't we use half the dose or use 2 grams instead of the other dose? I said, well, wait a minute, these are my patients. I'm not going to put my patients into a study where one half gets rituximab, but the other half gets intravenous placebo, and I'm purposely giving them a lower dose of mycophenolate than worked in the other studies. If this is going to work, it's going to have to work in a way that I would use it in clinical practice. So right now, we don't have that rituximab data. We do have some small studies that are very interesting. Here's a study on 20 patients treated with rituximab for lupus nephritis and followed for 12 months. 12 patients were refractory to standard therapy, 6 had relapsing disease. At 22 months, 60% of them were in complete or partial remission. So for resistant disease, it may work. Here's a study from the Imperial College. Now, this is when they had 21 patients. I was just at the UK meeting in Newcastle. They now have 75 patients. When they hit 100, they will publish they've already published 50 patients, whatever. They're moving along with this. They use a regimen that includes mycophenolate and rituximab. They only get Solumedrol when they get the doses of rituximab, no steroids. It's a steroid-free regimen in between. And remember, you only get the rituximab every 6 months here. So 76% complete remission, 9% partial remission. And again, this is without oral steroids. They're getting away from steroid therapy at the Imperial College. Very interesting trial. So my conclusions about the use of rituximab: it appears to work as rescue therapy for some patients with relapsing or refractory disease. It must be used with other therapies, but maintenance steroids are one of them. It can be used with mycophenolate, or it could be used with steroids, but you don't have to use steroids. Its role as a first-line agent for induction remains to be defined here. It may have a role in certain populations, blacks and Hispanics, it may work, but we need a study to show that. And in general, it's been very well tolerated. Progressive multifocal leukoencephalopathy, that fatal viral brain disease, has just not been a major concern in any of these studies. Now, rituximab, some of you may have seen Jason from this month's Journal of the American Society of Nephrology, came out this month. Ramuzzi has an article on 100 patients with idiopathic membranous treated with rituximab. One of his conclusions is it's a first-line agent for membranous. There's an excellent editorial that comes with this that says it's not the first-line agent for membranous. And I urge you to read it. I wrote the editorial, so I can tell you it's excellent. But it's important to realize it's not a first-line drug for anything. It's expensive, and it has to be shown in a randomized controlled trial, which we are now doing in membranous, comparing it to cyclosporin in membranous, but we're doing that trial here. But nevertheless, you have to study it in a controlled, randomized fashion before you say something is first line. Other therapies in the last few minutes. One is the thought of using multiple drugs. And again, this is being done again and again, but I put up this study by Bao. This is from the Zhihong Lu's group at Nanjing. They looked at their worst population. For them, people with membranous and diffuse proliferative superimposed. When they have that combination, their patients go downhill. They just have not responded well to other therapies. So they took a group, half of them got standard cyclophosphamide and steroids. The other group got a regimen here of mycophenolate, tacrolimus, and steroids. Here you can see complete and partial remissions with this multi-targeted therapy: tacrolimus, mycophenolate, and steroids. Many more complete and partial remissions at 6 months and better at 9 months as well. The thought of using other drugs as well. If your major problem is proteinuria, adding either cyclosporin or tacrolimus is going to make a big difference. That will drop the proteinuria for sure, and it helps in its immunosuppressive way too. So you have to think about this. For those of you who know that Benlysta was the first drug approved for lupus in the last 40 years in the United States, well, this is anti-BLyS therapy, belimumab. It's a monoclonal antibody. This is the data, the biggest study that it was approved on. It was approved on 2 studies, but they're really the same. If you look at here, the scoring system, they use SLEAN-I and SLEAD-I. Well, these are scoring systems that include joints, it includes rash, a whole bunch of other things other than hard numbers. If you look at the belimumab group, it is better, but it's only slightly better. It has not been studied in lupus nephritis. Until it is studied in lupus nephritis, I would prefer to say this is on the back burner. It is not a first, second, or third line drug. It's for resistant disease. Again, we just do not have the data. They're just starting to study it in lupus nephritis. I will be impressed if it works. Remember, the rheumatologists have everything in the world approved for rheumatoid arthritis because they count the number of joints that are involved. I mean, like, you can't do that in nephrology. In nephrology, you get proteinuria in grams per day. You get creatinine in milligrams per deciliter or micromoles per liter. You get a hard number. You have to show really solid improvement, and it's much harder to show. So we'll see if Benlysta or belimumab does well or not over time. 2 other newer agents, abatacept, Orencia. CTLA-4Ig is a co-stimulatory blocker. It is FDA approved for rheumatoid arthritis, like everything else I know. In a double-blind controlled trial in 300 patients here, the remission rate was low and not better than the control group. However, if you analyze the data here, the way they set up the study, it couldn't possibly work. The improvement that they wanted in GFR was still within the variability of the measurement of the GFR. So a rheumatologist from UCSF, Dave Wapsie, analyzed this and said, there's no doubt that it was going to be a negative study from the start. Well, I knew their study design. I was actually on the adjudication committee. I said the same thing. Dick Glassick was on the adjudication committee. He said the same thing before we adjudicated a single case. So what did they do? The company fired us. They fired the adjudication committee because we said it wasn't going to work. Didn't work. There is another trial. This is the National Institute of Health trial by the Immune Tolerance Network. We're part of this. It will look at using a background of cyclophosphamide by Lupus here, looking at abatacept and finding out whether co-stimulatory blockade works, again, in a large control randomized trial. So I don't think we should take this study as meaning that it doesn't work. This study just was not designed right. And finally, Laquinimod, I put this up. It's a small molecule that's an oral immunomodulatory drug. They list 3 different mechanisms of action, which probably are all true, but which one is the most important, I have no idea. But I put it on for a certain reason. We've just finished a 45-patient pilot trial here that it's not almost entirely, it is entirely enrolled, it's being analyzed. So you say, well, wait a minute, this is not an FDA-approved drug. Jerry, why would you use this in your patients with lupus nephritis? The reason I can use it in lupus nephritis is it's been studied in over 2,500 patients with multiple sclerosis. Some of you know there was a positive article in the New England Journal last December on something like 1,500 multiple sclerosis patients. I don't have any trouble with trying a new drug as an add-on to standard therapy if it's already been studied in 1,000 patients. I'm not going to get any big surprises in terms of side effects. And that's, again, one of the ways we can get into this, because many of the drugs are approved for other indications, rheumatoid arthritis, multiple sclerosis, etc. We'll be able to evaluate these drugs. So, a little different from the last slide you have, but not very different. What have we learned in the last decade? Treatment is divided into 2 phases, induction and maintenance. MMF and IV cyclophosphamide, and I put down by the Lupus regimen because I believe that are the first lines for induction. The routine induction of rituximab is unclear. Combination therapies are used all the time. We use steroids with these agents. You can use a calcineurin inhibitor with them. Both MMF and azathioprine are effective and safe maintenance therapies. Longer maintenance therapy may be beneficial. The development of entirely new drugs will all be by control randomized trials. And again, lupus nephritis makes me happier than almost any other glomerular disease. Now, you're going to hear about ANCA-positive RPGN next, but that's the other area that the progress has been the biggest in terms of this. But again, for other glomerular diseases, we don't have these large control randomized trials. That's what we need, and need to get a change in therapy based on true evidence. But the biggest thing is the need for creativity. One regimen does not fit all. When you treat your patient now, when you see the patient with diffuse proliferative disease, say what therapies have they had before, what side effects have they had before, are they interested in having kids, or are they now postmenopausal already? All of these things come into play, looking at the side effects and everything. That's how you choose your regimen. You have choices now. All the choices, though, are based on evidence-based medicine. Good, solid data that you can apply now to your patients. So we've come a long way in 1 decade.